very much for giving us this talk. Looking forward to it.
Thank you. Good morning to all of you. Let me outset thank you the BNSRC team for giving us this opportunity to share our thoughts about the imaging techniques in neuro ophthalmology. I have named this as cell to fiber imaging, and let us see what thoughts we can share between us. And nature have given a strong association between ophthalmologists, neurologists, and neurosurgeons. Let us thank the nature for the friendship that they have it has given to us. So this lecture will be based on basic functional anatomy and physiology of the visual system to understand what we are discussing about, and evaluation of the visual function, the principle of imaging, the current topic of discussion, its clinical applications, and some evidence-based approach and limitations. And of course, the future directions of our understanding. Now, let us begin with the basic system, functional organization of the visual system. I want to see this image. So this image is in space. So I should know what is this? Where is this? And of course, this forms the form, color, and texture, position, and movement. Once I appreciate this one, then what happens? There is a binocular coordination is required for this, and the motor and sensory response based on what I appreciate. All these things have to be known and processed at retina level or at higher visual function level. The functional organization of visual system, all of us at one point of time as undergraduates or postgraduates would have had questions from the examiners. What are all the 10 layers of the retina? Then what happened is we recite from our memory all the 10 layers, and after the exams we forget. Those were the days. But now the understanding of the each micron or each cell of the visual system is there, so that we don't need to commit to memory, but we have to understand what is happening. So like any other sensations, the organization of the visual system involves the receptor, the first order neuron, the second order neuron, and the third order neuron. The first order neurons and the second order neurons of the visual sensory systems lies within the retina. And of course, the axons of the second order neuron travel inside the brain. The third order neuron starts from the LGB to the higher cortical centers. Now, the retinal receptors basically are rods and cones. We have about 120 million of rods, which are responsible for the scotopic vision, and less number of cone, which is responsible for the photopic vision. What is scotopic vision? Vision in darkness. Photopic vision, vision in bright light. And of course, the cones are also responsible for the color vision. So these are all the retinal receptors. Now what happens is, let us now dissect each 10 layers of the retina. The first layer of the retina from outside in is the retinal pigment epithelium. Now this retinal pigment epithelium forms the trophic support for the photoreceptors. The second layer of the retina is the actual receptor. They are rods and cones. These are all the rods and this is cones. As I said before, the cones are responsible for the color vision, and there are 3 different types of cones depending upon the wavelength of light. Long wavelength, medium wavelength, and short wavelength. So now we have dissected the first 2 layers of the retina, the retinal pigment epithelium and the receptor being the rods and cones. And the third layer is the external limiting membrane. So this is only the foot process of the supporting cells. We don't need to go into this. The fourth layer of the retina is the outer nuclear layer. So as I said before, we don't need to commit to memory, just to understand. So first it has got the rods and cones, and the fourth layer is the outer nuclear layer, forms the cell bodies of the receptors. So the rods and cones has got various parts. The outer nuclear layer forms the cell bodies of the rods and cones. Now, the distribution of the rods and cones in the retina, this is the center of the retina where you have maximal density of the cones, and periphery you have the density of rods. The outer nuclear layer, as I said before, it forms the cell bodies of the retina, rods and cones. Now what happens? Then it has to make connections with something else. So like what we have in other parts of the nervous system, they make connections with the next layer of cells that is called outer plexiform layer. So the first receptor makes connections with the first order neuron in the retina that is called the bipolar cells. This connection forms what is called the outer plexiform layer of the retina. So the first order neuron is the bipolar cells, and these bipolar cells, they make connections and their cell bodies lies within the inner nuclear layer of the retina. So there are 2 nuclear layers, outer nuclear layer and inner nuclear layer. The inner nuclear layer, you have the first order neurons where it is called the bipolar cells. The bipolar cells are the cells where the first action potential is detected in retina. And of course, it has got some supporting cells called horizontal cells and amacrine cells. So the bipolar cells, there are different types of bipolar cells. They are classified according to their function and anatomical nature. To know very simply, they connect with single cone, that is called midget bipolar cells. And if they have connections with many cones and rods, it is called diffuse bipolar cells. Why we need to know like this? This is the scene what we see in the retina. The bipolar cells is the first cell to have the action potential and the first cell to have what is called the receptive field. Suppose if I see this, the bipolar cells get stimulated when the light falls in the center, and they keep quiet when the light falls in the periphery of their visual field. This is one type of bipolar cells. So the bipolar cells gets connected to the ganglion cells of the retina. Now, this is very, very important. The color sensitive cones connect to the special type of bipolar cells and special type of ganglion cells. Now, this is an MCQ in exams for ophthalmologists and as well as for the neurologists or the residents appearing for the basic sciences examinations. Now, the inner plexiform layer is a connection between the first order neuron and the ganglion cells of the retina. The ganglion cell of the retina is the hero of today's topic. The retinal ganglion cells there are about 22 types of retinal ganglion cells. They are classified into parvocellular, magnocellular, coniocellular, and melanopsin containing ganglion cells. Now, these retinal ganglion cells, now they are going to detect what and where pathway. So the parvocellular are larger, smaller in size, they are more in number, and they detect the detail and contrast. Whereas magnocellular is 10 to 20% only. They are responsible for the motion detection and contrast. Coniocellular, low contrast, and this is very, very important MCQ for all residents. There is something called melanopsin containing ganglion cells, which is responsible for the pupillary light reflex. This is an MCQ or a famous question. The classifications of ganglion cell is based upon the field size, the dendrite shape, compactness, and anything. Now, this is very, very important. There is something called melanopsin containing retinal ganglion cells. They receive input from rods and cones, but they are self-active, meaning suppose if I throw the light on the retina, these melanopsin containing retinal ganglion cells can get activated themselves, independent from rods and cones, and they are responsible for the pupillary light reflex, which they get transferred at the pretectal olivary nucleus. And this melanopsin RGC is also responsible for the circadian rhythm, and it goes to the suprachiasmatic nuclei of the hypothalamus. This is very, very important because some conditions, retinal conditions say, suppose if you have destruction of the outer layers of the retina, still the pupillary reflex can be there. That is because of the melanopsin containing retinal ganglion cells. Now, this is the distributions of the rods and cones in the retina. Why we need to know this? The rods are in the periphery and the cones are in the center. And our hero, ganglion cells of the retina, are more in the center, or otherwise called macula of the retina. Now, what happens is, after the ganglion cells, it forms the nerve fiber layer of the retina. And as you know, the nerve fiber layer, there is a vertical transition or cutoff at the macular level where they form the crossed and uncrossed. But we have to understand that this crossing and uncrossing truly doesn't happen at the optic nerve head level. This is very, very important factor to understand. There is a horizontal stratification occurs. The superior fibers goes to the superior area of the optic nerve. The inferior fibers goes to the inferior area of the optic nerve. Nasal fibers comes here, but there is a real mixing occurs because the optic nerve is a very small space. It is about 1.2 millimeters only. So the real stratification of the crossed and uncrossed fibers occurs as the fibers move posteriorly. This is a very important point to understand. So now to summarize, not to commit from memory, these are all the 10 layers of the retina. And what we have to remember is the nuclear layer is darker. The connections are lighter. Why? I will say this later. See, all the nuclear layer or the ganglion cells layer which contain the cell bodies are darker. And this is the receptors of the retina, rods and cones, and this is choroid. Now the beauty is going to start. This is the optic nerve where the fibers exit, and what we see as the optic nerve in the ophthalmoscope is called the optic nerve head. Actually, the optic nerve head is made up of 4 layers: the superficial nerve fiber layer, retinal layer, choroidal layer, and scleral layer. Why this transition or division is important? The superficial layer receives blood supply from the retinal capillaries, where the deeper layer receives blood from the choroidal circulation or ciliary circulation. This stratification or this division is worth remembering. Now, as I said before, this is the organization of the fibers at the retinal or of the optic nerve head level. As it moves posteriorly towards the chiasma, now the division occurs. The macula comes to the center and other divisions of the retinal nerve fibers or the optic nerve head fibers occurs. And at chiasma, the true division occurs. This is very, very important. And as I said before, the magnocellular, parvocellular, coniocellular, and melanopsin is a mixed. Each apparal temporal, each apparal nasal has got all these fibers. And that is why we are able to see the system. I am not going into the other details, but what happens is, again, the stratification occurs at the lateral geniculate body level. We have all the 6 layers, 4 layers for the parvocellular and 2 layers for the magnocellular, again division, layer 1, 4, 6, 2, 3, 5, all those things. But what happens is, at the suprageniculate level, from the cortex and pericortical or peristriate areas, the what and where pathway gets segregated. So this is called dorsal pathway or M retinal ganglion cells. The magnocellular pathway, it goes to the V5 and parietal lobe, and the ventral pathway, what pathway, it goes here. And depending upon this, the disease can affect each of these separately. Now we are not of interest that one. So the ganglion cells, the hero of today's topic, can get affected by glaucoma, the neurological causes, vascular causes, or retinal causes. How to assess this ganglion cells and axon? There may be structural assessment or functional assessment of the ganglion cells. Basically, the functional assessment is done with the vision chart. This is called the logmark chart. Actually, this gives better resolution or spatial resolution and contrast sensitivity. Functional by color vision. This is the Ishihara's chart, and this is called the Farnsworth test, where we assess the color vision, of course, pupil and fundus examination, and visual field. Now there are techniques available to segregate or assess the visual field separately. The magnocellular pathway can be assessed by what is called frequency doubling perimetry, or recently what is called the flicker perimetry, and coniocellular pathway can be assessed what is called by short wavelength perimetry. Why this division is important? Because in conventional perimetry we use white background and white object, but studies have shown that the retinal ganglion cells and axons can get damage up to 30 to 40% level before it gets reflected into the white and white perimetry. So that is why functional assessment of the ganglion cells is possible with modern stratification of the perimetry. There are different types of perimetry that is available. And of course, by ERG, the standard ERG and multifocal ERG. Each point of the retina can be assessed by multifocal ERG, and of course, VEP and multifocal VEP. The structural imaging, of course, neuroimaging, and the what is called optical coherence tomography. What is optical coherence tomography? It shines a laser light into the retina, and it dissects the retina at various levels and gives images. Now what happens is, it shines infrared light into the retina, and this goes into the retina and it gets reflected back, and the images are captured and it is processed, and each layer of the retina is now given up. This is the OCT machine what we have. Now, this is retina. Suppose if I want to do an ultrasound of the retina, just I send this sound wave like this, and we measure the distance the sound has traveled and come back, and we get images like this. Whereas in OCT, what happens? in transverse images. It cuts the retina like this and it gives the retina all the layers. So it is a light rather than the sound, and it gives higher resolution and non-contact method of examination of the retinal cells. Of course, clear media is required for this. This is the normal macula, what we would have seen in our textbooks, the retina. As I was talking, the 10 layers of the retina. Now I can see all the layers of retina in front of eyes without any dissection. So it is an optical biopsy of the retina of various layers. Now I can dissect all the layers of the retina. Now this is the histological specimen of the retina, where I can see all the layers. As I said, the nucleus is darker. So this is the outer nuclear layer of the retina. This is the inner nuclear layer of the retina. So this is the outer plexiform layer. This is the inner plexiform layer. This is the ganglion cells of the retina and the nerve fibers of the retina. So whatever you are seeing in the histological specimen, now I can see in front of my eyes. And of course, false color code is given to understand or separate each layer of the retina. I can see the choriocapillaries. I can see the retinal pigment epithelium. I can see the retinal photoreceptors. And with modern machines, even the outer and inner segments of the photoreceptors can be seen. Now, whatever that is seen as histologically and the connections. So basically, we are interested in rods, the bipolar cells and ganglion cells. Now I have in front of my eyes, I have the ganglion cells, I have the bipolar cells, I have the rods and cones in front of my eyes. In neuro ophthalmology, it is used to measure the retinal nerve fiber measurements and the macular ganglion cell layer. Why macula? Because the ganglion cell has got maximal density for at least 10 layers at the macula. Periphery in the macular ganglion cell thickness comes down. This is the nerve fiber layer analysis. Now what happens is the machine takes this strip of retina closer to the optic nerve, and these are all the 10 layers of the retina. Now, and it gives a statistical outlook. This is within the normal limits. This is suspicious, and this is definitely abnormal. That means it measures the retinal nerve fiber layer close to the optic nerve. So any disease of the optic nerve, right from the optic head to the lateral geniculate body, can get affected because of this, and we can know what is happening here or measure the thickness. And it can dissect the optic nerve head. I can see the cup, I can see the vessels, I can see the retinal layers closer to the optic nerve, and it gives the thickness of the or all the parameters of the optic nerve head. And these are all the other facilities available. I can move this cursor close from the top of the optic nerve to the back. So now this is the choroidal circulation or the choroidal opening, where I can see the choroidal vessels which can get affected in certain diseases of the optic nerve head. Then macula, I can dissect the macular ganglion cell layer by layer. Now this is the macular general analysis. It gives the thickness of the general macula. That means it includes the retinal nerve fiber, macular ganglion cells, and of course the cone. But I can go one step further, where I can measure the thickness of the retinal ganglion cell, both upper quadrant, lower quadrant, nasal quadrant, temporal quadrant, and each cell I can see, or each quadrant of the retina or the macula can be assessed in this way. Next, I can get a three-dimensional picture of the macula, what is happening under the macula, and even the choriocapillaries or choroidal circulation can be assessed with the help of what is called angiography. Now, even this choroidal, these are all the larger choroidal vessels, and I can see all these things. And to see you, this is not neurology or neuro ophthalmology, but still you can appreciate the small hole in the macula, which can be seen very clearly, where in the fundus picture you may not be able to appreciate. Now our treatment modality is based on the OCT measurements. Early detections of the retinal diseases or the macular diseases can be made. And this is called OCT angiography, where it is a non-invasive method of study of the macular circulations. The macular circulation can be assessed at superficial layer, middle layer, and the retinal capillaries can be assessed. As you know, these retinal capillaries mirror the changes in the cerebral circulation. And this is a small tumor growing from the choroid, which can be seen very clearly, and the vascularity of the tumor can also be assessed. And this is the way in which it gives the macular report. It compares between the upper and the lower area of the ganglion, and it gives a statistical report. Now, OCT in neuro-ophthalmology, the evidence-based approach. Multiple sclerosis is a common disease what we encounter both in ophthalmology as well as in neurology practice. These are all the evidence-based that is available right now. The thinning of retinal fibers are seen even in the absence of optic neuritis. This is a very, very important marker. So you don't need to have optic neuritis, but even thinning of retinal nerve fiber layer measurements are important in multiple sclerosis. Axonal loss and axonal subclinical loss, even in patients with normal visual fields in multiple sclerosis. The retinal nerve fiber layer thickness correlates with the neurological and visual functions. And this has been studied in various studies with multiple sclerosis and OCT. The visual fields may be normal, but retinal fiber layer thinning has been observed in the absence of clinical or markers of optic neuropathy in multiple sclerosis. A moderate association has also been shown with MRI findings in MRI markers, the MRI plaques. But as you know that MRI plaques features depends on so many other factors. Not a strong association, but a moderate association has been seen with RNFL or retinal nerve fiber layer measurements with MRI findings of brain atrophy. And retinal fiber measurements alters the cup disc ratio in patients with multiple sclerosis, and this has been proved. And more important, more than the retinal nerve fiber layer assessment, the ganglion cell assessment, it is a marker for multiple sclerosis. Changes in the ganglion cells can occur, and it can detect the damage before the retinal nerve fiber layers gets affected in various types of multiple sclerosis. And one point to note, even this can occur even in the absence of optic neuropathy and normal visual fields. This is a very, very important finding. And the changes in the retinal nerve fiber layer and ganglion cell layer can occur as a time of function also. And progressive changes in the ganglion cell occurs according to the neurological impairment with EDSS scale. Again, this is a very important finding. And follow-up or patients treated with multiple sclerosis with fingolimod, they can have what is called macular edema. Of course, the multiple sclerosis, apart from optic neuropathy, can have other markers in the eye, like sheathing of retinal blood vessels, or it can present with about 1 to 2% of the patients can present with pars planitis, that is the inflammation of the uvea, and the patient can have retinal edema or macular edema. Especially the patients with fingolimod therapy, like what we screen patients with ethambutol, an ophthalmic examination is necessary before initiating and in follow-up of patients with fingolimod therapy, because it can detect subtle macular edema. This is an important finding. And of course, Now, the recent thing is multiple sclerosis patient can have what is called microcystic macular edema and the inner nuclear layer of the retina. In the inner nuclear layer, the bipolar cell layer of the retina, and it correlates with the activity and disability of multiple sclerosis, and it is a predictor for the progression of MS. Of course, this microcystic macular edema can occur in other retinal conditions also or other optic neuropathy. We have to take this in account. But in the setting of multiple sclerosis, when a patient has microcystic edema, we have to consider this. And in different forms of multiple sclerosis, for example, in progressive, secondary progressive form, the retinal nerve fiber thinning is more, and the macular volume is affected comparing to the primary progressive form of multiple sclerosis. This is an important finding. And in NMO spectrum of disorders, as you know that MS is now, NMO spectrum is separate from multiple sclerosis, thinning of retinal nerve fibers, and more, the ganglion cells are more affected in certain quadrants of the retina, even in the absence of optic neuropathy. This is a very, very important. That means your ganglion cell analysis is very, very important. And this is a study showing the angiography, patients with multiple sclerosis and optic neurosis, and NMO with optic neuropathy. Even in patients with NMO without optic neuropathy, there can be changes in the retinal capillary plexus. And very, very important, prognosis after optic neuropathy. If the patient has got an optic neuropathy, when there is a thinning of the retinal nerve fiber layer, then the prognosis can affect the visual dysfunction. And it has been accepted that macular ganglion cell analysis, series of macular ganglion cell analysis is a biomarker for multiple sclerosis now. And a subset of multiple sclerosis patient, they may have thinning of the nuclear layers of retina, which is related to the disability progression, and this has been proved also. And studying the retinal capillary vascular network marks the activity of disease activity in multiple sclerosis. So the multiple sclerosis, it is a very useful tool to assess the progression and of course the presence or absence of optic neuropathy or optic nerve involvement. And even the recent study shows that OCT is helped in the differential diagnosis of patients with non-specific other patients with multiple sclerosis and other non-specific white matter lesions, and changes in the retinal nerve fiber layer and ganglion cell layer has been documented, and OCT is a helpful tool in the differential diagnosis of MS and non-MS white matter lesions. So OCT is included in most of the clinical trials of MS now, and it is used in the assessment of the disease activity of multiple sclerosis and optic neurosis, and possibly the treatment strategy also. And of course, we have to wait for the other future advancement in this. And other areas wherein OCT is used is anterior ischemic optic neuropathy. You know, it is basically an ischemic and non-ischemic type. The non-ischemic affects the choroidal circulation, and ischemic usually follows the GCS. GCL, the ganglion cell biomarker. GCL is a biomarker for the non-arthritic ischemic optic neuropathy. Suppose if you have a patient with non-arthritic ischemic optic neuropathy, acute onset, and if there is a GCL thinning in this patient, and the visual prognosis can be bad comparing to the person without thinning of the ganglion cell layer. This is an important marker in non-arthritic ischemic optic neuropathy. We can study the retinal circulation. This is one of our patients with non-arthritic ischemic optic neuropathy, and you can see the dropouts of the retinal capillary, the retinal capillaries adjacent to the optic nerve head in this patient, and it can measure or it can show the presence or absence or leak in the retinal circulations also. And the non-arthritic ischemic optic neuropathy is usually associated with smaller optic nerve head. It can measure the disc size, and it can tell us what are all the other causes of visual loss in ischemic optic neuropathy. One of our patients had a fluid underside in the macula, and this may be the cause of visual loss. And you can see the thickening of the retinal ganglion cells and retinal on one side. And of course, for our neurosurgery colleagues, papilledema, the role of OCT to differentiate between true and pseudo papilledema, and quantifying the papilledema, and to document the other cause of visual loss in papilledema, maybe presence of subretinal fluid, the detection of the nerve fiber layer loss. This is very, very important, because whenever papilledema is treated, a regressing papilledema, because of control of intraocular pressure, the inner layers of the retina may be lower. But if there is an axonal loss, there may be thinning of the retinal nerve fiber layers and the ganglion cell loss. So measuring this can detect early loss or early visual dysfunction, and we can modify our treatment based on this. This is one of our patients with papilledema. So we can see the disc edema and the congestion of the vessels, and you can see the elevated optic nerve head and the congested blood vessels in the optic nerve head. This is to diagnose. And the visual loss in optic nerve edema, if the axonal loss or the ganglion cell loss is severe, say there are two patients with optic nerve edema. Patient A, the axonal loss or the ganglion cell is normal or less affected, whereas patient B with the same amount of edema, if there is a ganglion cell loss is more, then the patient B may require more aggressive treatment. And it can detect the other cause of visual changes like presence or absence, because the edema or the papilledema can cause visual loss in many ways. One, the axonal loss. This may not be in the acute stage, but that can be presence of macular fluid or choroidal folds. So this can differentiate the various cause of visual loss in optic nerve edema. So this is one of our patient. He was treated, and you can see the pallor of the optic nerve head, and we made a ganglion cell analysis. There we can see the thinning of the ganglion cells in this patient. The thinning is more on the right side comparing to the left side. So if there is progress, so say today I make the measurement. Say after 1 or 2 months I make measurement. Suppose if there is a progressive thinning, there may be pallor of the optic nerve head, but the ganglion cells can thin in a matter of time. Then that means that we need more aggressive treatment in this type of patients. This is again one of our patients who had bilateral papilledema recently, and this is to diagnose. So of course the diagnosis is straightforward, but I will show the later the other slides also. You can see the elevated optic nerve head in the OCT measurement. And this is one more, the second patient, where you can see the pallor of the optic nerve head and thinning of all the layers of the macula. So this is a macular scan where the red shows that there is a thinning. And of course, for the postgraduates and residents support, if you pay attention to this part of the optic nerve head, this is a very famous exam question. You can see what is called optociliary shunt. The shunt occurs between the choroidal and retinal circulation. This can occur in any form of chronic swelling or chronic pressure on the optic nerve head. This is a famous exam question. And it is helpful in benign ICT follow-up also. I can measure the ganglion cell in the initial stage, and the loss can be measured, or the changes in the retinal nerve fiber layer can be measured as time goes on. And this is a very important study which says that the macular ganglion cell layers and thinning at presentation in patients with untreated benign ICT, this patient may have a worse visual prognosis. That means a patient with normal ganglion cell thickness during a follow-up is a good prognostic sign for recovering of this patient. And OCT in other neurodegenerative disorders, in Alzheimer's disease, it has been shown that there is reduction in the retinal nerve fiber layers, and it is related to the MCA also. Suppose if we are able to detect these patients at an earlier stage, then we can give different treatment, or therapeutic approach may be different, or support can be better for these patients. For this, various studies have shown that in Alzheimer's disease, the retinal plaques or the study of the retinal vessel map helps. This is the normal, and in Alzheimer's disease, there is dropout of the macular vessels in an earlier stage, and the perfusion density also can be thin in case of early Alzheimer's disease, and thinning of retinal nerve fiber layer is also observed. So again, ganglion cell analysis is a good biomarker for Alzheimer's disease. There are retinal biomarkers for earlier Alzheimer's disease. This is under studies now. You can study hard drusen and presence or absence of beta amyloid protein in the retinal disease. This can be detected with OCT, and measurement of certain areas, retinal areas of the retina, especially retina volume analysis of the macular ganglion cell, and vessel anomalies, and changes in the retinal capillary plexus, as I showed before. These may be the early markers of Alzheimer's disease, and this is under study now. And of course, this is also useful in Parkinson's disease. In early Parkinson's disease, it has been demonstrated that the nerve fiber layer is thinned out comparing to the controls. And of course, to diagnose pseudo-optic nerve edema, drusen of the optic nerve head, this is an important differential diagnosis for pseudo-papilledema. The drusen of the optic nerve can be a buried one, or it can be present on the surface. This is one of our patients where this is the drusen of the optic nerve head, and it can show thinning of the macula. And in drusen, this is shown as an elevation comparing to papilledema, where the dilated retinal vessels. Here you can see the drusen per se within the optic nerve head. This is the ultrasound where you can see the drusen, and there are other biomarkers of the OCT where we can say that clearly it is a drusen, especially in the case of buried drusen, where it can mimic a pseudopapilledema, and we can avoid unwarranted neurological or neuro-ophthalmic evaluation. And pseudopapilledema because of myopia. Myopia is another differential diagnosis of pseudopapilledema. It can show tilted disc, and I can see the tilted disc here and measure, and I can see changes in the retina also in case of pseudopapilledema because of myopia. And other areas under investigations, optic atrophy, congenital optic atrophy, even it is related to the mutation. One type of optic atrophy where there is a mutation of OPA gene, where the ganglion cells are symmetrical, and it affects in particular quadrant of the retina. And this is of course for more research purpose. And it is different types of imaging of the retina is useful for assessing the structural changes in various forms of optic atrophies, especially the congenital optic atrophy. Of course, it is useful for other optic neuropathy also, traumatic optic neuropathy, toxic optic neuropathy, and compressive optic neuropathy. So for neurosurgical colleagues, we can do the preoperative measurement of the retinal nerve fiber layers and ganglion cells. Though the patient may have a visual field loss, we can actually see what is happening in the retina, and we can predict the visual prognosis. Suppose if the pressure is for long standing, it can produce changes in the ganglion cell layer. We can affect the we can predict the visual prognosis. So this is one of our patient. He had meningioma, and you can see the right homonymous hemianopia. So the visual field only shows a right homonymous hemianopia, whereas the macular ganglion cells, if you see, both the quadrants of the macula are affected. So that means that there is something else, or the pressure is more diffuse than to cause more right homonymous hemianopia alone. And this is one of our patient. She had a T-cell lymphoma and she was treated for that. This is the suprageniculate lesion. Normally, the basic teaching at our resident level is that transsynaptic degeneration is rare, or you don't see changes in the retina because of a suprageniculate lesion. But this patient, she had a meningioma and lymphoma, and she was treated, and she had a left homonymous hemianopia, and that is clearly seen in the ganglion cell analysis. Each half of the retina was affected. Her retinal nerve fiber layer also got affected. So this is one of where the transsynaptic degeneration can be seen both on the visual field as well as on the OCT. This is another patient, one of our patients with systemic lupus erythematosus. You can see only few spots in the retina, the soft spots in the retina, or the cotton wool spots. But we did a OCT angiogram. There was widespread dropout of the capillary circulations in the retina at various levels. So OCT future directions, of course, there will be a lot of newer algorithms, newer machines, and we are expecting the Doppler OCT, and it can help in yearly diagnosis and follow-up of lot of neuro-ophthalmological cases, including space-occupying lesions, and this will be a very good diagnostic and prognostic tool in our management of patients. And finally, I always like mathematics. Sin by Q is equal to, thank you for your attention, and I can take up any questions.